retrain trial, and this will be presented by Cossack Chatterjee, United Kingdom.
Thank you. So good afternoon, everyone. I'm one of the stroke physicians in Liverpool, in UK. We're going to talk about transcutaneous stimulations and the effect of it on the brain hemodynamics using FNIRS. But nothing to declare. This trial was funded by Innovate UK, which was a part of the Medical Research Council in the UK. So we're going to talk about a little bit of background, we're going to talk about the retrain trial phase 1 of that, talk about the results, and then end up with the discussions. Also, there is some analysis on what's happening with the hemodynamics, who is responding and who is not responding to it. So in the background, the brain damage after stroke happened over a period of time. So initially there is a vasodilatation, and then oxygen extraction fraction goes up, then eventually it goes down and the tissue dies. And the process itself can take up to 36 hours. The autoregulation goes, and as a result, the question is, if you actually increase the brain blood flow, particularly at the capillary level, whether that could reduce the final infarct volume and improve the outcome. So that's the background of it as such. We know that the rhythmic muscle stimulation can increase the preload to the heart, and as a result, it increases the perfusion to the brain and the other organs in the body. The other part of it is, this is the results from the CLOTS-3 trial. It was published, I think, more than 10 years ago. It reduced the DVT rate, but it didn't reduce the PE rate. But still, there is a significant difference in mortality. Was it because of the intermittent pneumatic device increased the brain blood flow, had a reduction in the final infarct volume, or was it because they had less DVT burden, so they are more mobile, so there's complication with that? So they didn't measure any brain blood flow at all. They didn't measure any other part of it to answer the question why there is a less mortality in the IPC group. There is another equipped device we can use to prevent DVT. It's called Gecko device. It's a small battery powered device. It sits on the perineal nerve there, and it stimulates the perineal nerve. What we know that this device actually increased the venous return 30% more than the intermittent pneumatic device. And in the UK, this is actually licensed to be used in people who cannot use the IPC. So before getting into the retrain trial, we actually used it in healthy volunteer, the Gecko device, so that things goes from 0, which is no stimulation, to maximum stimulation. And as you can see, the brain blood flow goes up in the healthy volunteer. These are all PhD students, so they needed some extra brain blood flow, but it was actually a linear relationship, what we showed there. So based on that, we first wanted to test it out, whether actually it works in the stroke patients or not. And retrain phase 1 is actually that, to test it out in different positions and in different intensity. Unfortunately, the regulator didn't allow us to use all the way up. They wanted us to use for the optimal level, but we actually said the optimal level could be different for different nurses, how they're looking at it. The optimal level is to the stimulus which moves the red toe up like that, and that should prevent the DVT. So using on the existing license, so that's why it didn't go all the way up. So this was the trial, this was a prospective observational single-center trial. We only used it on ischemic stroke because in the hemorrhage this is different. We tested in 3 different positions: lying flat, semi-supine at 45 degrees, and sitting upright. And we actually tested in optimal level, below optimal level, and then 2 levels up. Every time is recorded for 5 minutes, and we have a rest period of 5 minutes in between. So for our patients, the recording time is around 3 hours, with different things, with gaps and other things. So we actually recorded it in 2 or 3 different sessions rather than single sessions as such. We used FNIS to see the cerebral hemodynamics. It's actually, you've got a light source there, you've got an optical detector there. We use something called NIRS port 2, 16 by 16 detector, and light sources there. And that was the montage we used for this trial. The data analysis was done by the biomedical engineer, so I don't know much about it, but what they're looking at is HbO is a oxyhemoglobin, HbR is a deoxyhemoglobin, addition is a total hemoglobin, and the ratio is called StO2 there. It's a quite streamlined pipeline detections of the brain blood flow with this FNIS machine. So coming to the results, so we had 18 participants. So the stroke age is between 76 and 3. It was a rehab center where we did. So it was 1 month after their stroke, and at the time of the monitoring, so the detection, the NHSS rate was around 4 at the time of their this thing, but they are in the rehab unit, so admission in NHSS was much higher than that at that point. This was the baseline character, so we have few on the total anterior circulation stroke, which is quite significant stroke. These people are having rehab anyway. Also, we looked at their carotid disease with the radiologist, size of the infarct, and whether they have any ICAS or not to see its effects there, this thing or not, along with the comorbidities. So this is what we found. So the effect of the Gecko device is actually similar. In the volunteers, we actually only tested in sitting positions, and it looks like semi-supine and sitting positions are the best in terms of this, because lying flat, there is no difference. Particularly if you look at the results on the top left-hand corner, the baseline did drop actually when they're sitting, and as a result it becomes statistically significant. And the increased blood flow is actually quite diffuse, as you can see the bottom figure there. Then we used the top quartile, who actually had a highest response, and the bottom quartile to see who didn't have a response. So it just says responder is the top quartile, rest of the non-responder, and look at the characteristic of them. So in terms of things, it looks like if they have a cortical lesions, which is probably luxury perfusion, and if they have a carotid stenosis, they've probably got more collaterals, they are more likely to be responders than the non-responders there. Age, actually, younger patient had a better responder in the invariant model. In the logistic regressions, again, the cortical lesion was the strongest predictor who was going to respond to that as well. We also run the data on some 2 machine learning model, and they're quite showing similar results, that the NIHSS score, the age, lower age, and the cortical lesions are the 3 most things, and the 4th one is that if they had ICS stenosis there. So what do we understand about the results actually? So this was the phase 1 of the 2-phase trial. So we have seen a positive hemodynamic response to this device with the FNIS as such. There are a few factors we identified. They are going to respond better than the others, but this is a single center trial with a modest number. FNIS is susceptible to motion artifact, so there is some external validation which is required. We're running the phase 2 trial, and which is a randomized trial. We are comparing the blood flow to the brain between the Gecko device and the IPC to see if there is any difference between that, or also we are looking at the outcome data as well, but we are not powered to see the difference in the outcome in the phase 2. So just want to finish thanking my colleagues who did that intensive monitoring for 3 hours with the patients. And it's very difficult to do the monitoring for 3 hours without telling patient not to talk, because FNIS is like a bold MRI. So fMRI, say in the top he could see the signal suddenly going up that way. Thank you very much.
Thank you. That was a very interesting and a great presentation. Hopefully, in the future, I guess you could do this in a much larger cohort, and so that you can attract, a more diverse patients. And I guess we'll look forward to that. This is very interesting. Like it. Any questions?
One quick question.
Go ahead.
So do you know why there's increased blood flow of patients in semi-supine versus flat? Is there kind of a physiological mechanism behind that?
I think probably what it looks like, the baseline is dropping, and that's why you are seeing that spike. Also, we have seen it didn't happen immediately because we monitored for 5 minutes. So after 100 seconds, it's actually spike going up. So it's not an immediate effect. So it looks like real rather than something we're picking up as a signal.
Any other questions? All right. Thank you.
Thank you very much.